Good morning, good afternoon, and good evening, everybody. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Welcome to the sixth webinar in the series on transforming care for small and sick newborns, which is organized by UNICEF and WHO with the support of the Quality of Care Network. You will see that you are all muted during this webinar. You will have about 30 minutes of presentation by 3 speakers, followed by 30 minutes of question and answers. So please, during the presentation, type your question and your comment in the chat box on the bottom right corner of your screen, and we will read them out in the second half of the webinar, and the panelists will have a chance to answer them. We are also recording this session and playing it on YouTube. And later today, we'll be sending you the link with the recording as well as the presentations to all of you who registered for today's session. I would like now to introduce you to this morning's facilitator, Dr. Ornella Lincetto, who will facilitate the session, introduce you to the panelists, and the run of the show for today. She is Senior Medical Officer for Newborn Health at the World Health Organization in Geneva. Over to you, Ornella.
Good afternoon, good evening. Welcome to everybody to this sixth webinar on Survive and Thrive, Transforming Care for Every Small and Sick Newborn. Today, we will discuss the sixth chapter, which is focusing on the call of action, and we will explain why action is needed and what can be done to accelerate progress for reaching the SDG target for newborn health. And I would like to, again, remind that the report has been a collaboration of many partners around the world. And with these few words, I would like to introduce the presenters of today and the agenda. So we will have a presentation on the key findings and the immediate actions that are needed from the key findings from the chapter 6. This will be done by Judith Robb McCord, who is the Vice President of Technical Leadership Support at the Project Concern International. And she's one of the co-authors of this report. And then we will have Dr. Victoria Chu, who is an assistant scientist in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And then after the presentation on chapter 6, I will make a short presentation on the importance of modeling and data collection on maternal newborn outcomes and as well as services in relation with COVID-19. And we will close with the question and answers. Over to you, Judith.
Thank you, Ornella, so much. Good morning and good afternoon to everyone. It's a pleasure to be here today. And I thank you so much for your participation. As you've heard from Ornella, this is the presentation on the sixth and final chapter of the Survive and Thrive document. And our vision when designing the document was a call to action based on data and evidence about what needs to happen to transform care for every small and sick newborn so that they survive and thrive into the future. I'd like to acknowledge all of you who are facilitating its dissemination and call to action at the country level. This has been a truly collaborative effort designed to ignite action for improved neonatal outcomes, and it's a privilege to share highlights from chapter 6. We created 3 key messages for this chapter, and essentially we know what works to save the lives of women and newborns and to prevent stillbirths. If we can expand coverage of key interventions before, during, and after pregnancy, 2.9 million women, newborns, and stillbirths could be saved by 2030 in 81 priority countries. In addition, by investing in quality newborn care, 1.7 million newborn lives could be saved each year, and nearly half of this impact would result from providing special and intensive hospital care for our small and sick newborns. And finally, to reach our SDGs and the ENAP targets to end preventable newborn deaths by 2030, care for small and sick newborns must be transformed through collective stakeholder action, health systems improvements and investments, information, innovation, and implementation of proven interventions. Regarding the lives saved analysis, I'd like to hand over to Dr. Victoria Chu, who, as Ornella said, is from Johns Hopkins University Bloomberg School of Public Health. Victoria will take us through the lives saved analysis that she and her team conducted, building from the Lancet Every Newborn series. Victoria, over to you.
Thank you. Thank you, and greetings to everyone. So my goal for today is to highlight the analysis that was conducted to support Chapter 6 and to sort of discuss what the analysis entailed, what the assumptions were, and what the implications are for moving forward. Next slide. So briefly, I think everyone has heard about the Life Safe tool, as referred to briefly as commonly as LIST. And what this model allows us to do is it's an evidence-based platform that allows us to integrate the impact of multiple interventions. So for those interventions that our colleagues have said we know what works, the effectiveness of those interventions is integrated into a model that's a linear and deterministic platform that allows us to say these are the key interventions which are valuable and should be scaled up in low and middle income countries. These are the current levels of coverage, and those current levels of coverage, if expanded or increased, could lead to these benefits. So the advantages for us are our analysis was comprised of the countdown to 2030 countries, 81 of those countries which represent the large proportion of the global burden of both maternal deaths and children under 5. And we looked at the baseline scenario to say if nothing was to change, if we all were to sort of accept status quo, the baseline compared to 4 different scenarios. And so those 4 scenarios are sort of estimating the impact or the gains that we would expect to see if we were to achieve different targets. And so we had targets set for 2025 as well as 2030. And as I mentioned, what this model allows us to do is to look at cause-specific mortality change directly attributable to scale-up of intervention. So the take-home message, or the final sort of conclusion that the large sort of this analysis, multi-country analysis, incorporating those 81 high-burden countries, we would be able to save 2.9 million lives of women, including the subgroups of women, stillbirths, and newborns in those countries if we were to scale up coverage of those key evidence-based interventions. And most of those interventions, as we sort of described and discussed, are those that are provided before, during, or at or around the time of pregnancy or childbirth. So what we'll notice is that the LiveSafe tool allows us to look at these subgroups and say, of the current, compared to baseline, of the number of deaths that we would expect to see among maternal deaths, among neonates, and among stillbirths, what percentage of a decline would we anticipate if we scaled up coverage of those key interventions? So as I mentioned, the primary determinant is coverage change. If we scale up those interventions to reach more women and neonates in need at the time those interventions are needed, these are the expected declines in terms of the gains that we would see. And so the 2.9 refers to all of those component subgroups. Next slide. So from the sort of large envelope of this is the impact, because we're looking specifically at scale up of discrete interventions, we're able to analyze which interventions are sort of the leading drivers or contributors to the mortality reduction that we're seeing. Based upon the analysis, the 747,000 newborn lives would be directly attributable to scale up of special and intensive care level, hospital-based care for the smallest and sickest newborns. And so for us, what we're able to say is this is the overall impact, the total envelope, And then within that, which key interventions are really sort of the largest players or the largest contributors? Next slide. So our analysis looking at the 4 scenarios allowed us to look at quality of care. Next slide. So for the current LiveSave tool, our coverage of key interventions, which we broadly conceptually define as the proportion of women or children in need of an intervention who receive it as the numerator over the denominator of all of those in need. When we look at scale up of those key interventions, the coverage is influenced by 2 key factors. One, which is utilization. In other words, what percentage of women are seeking antenatal care, what percentage of births are occurring in a health facility. And then the second component is quality of care, because as we all know, the indicators which are tracking utilization only are insufficient to capture the quality of care. For the impact of those interventions to truly be realized, the quality of care that needs to be received for these specific interventions, for the key factors that the key contributing interventions we'll describe in the next slides. Improving quality of care refers to these high impact interventions related to, for example, neonatal resuscitation, immediate assessment stimulation, IPTP, of the causes, the 3 main causes, when we look at by intervention, what is the impact of each intervention to contribute to these specific neonatal causes of death. That allows us to design strategies or approaches that would be most effective for these 3 main causes. So the first slide we're showing here refers to those interventions which are contributing to the intrapartum related neonatal deaths. And obviously the largest component of that is appropriate management, labor and delivery management. Next slide. The second component related to infection as the cause of neonatal death could be addressed as you sort of see by like the colors and the contributions of the interventions. There's a wider range of interventions that would be effective and that would be contributing to our prevention of infection-related neonatal death. Next slide. The third leading cause related to prematurity. The interventions here, as I mentioned, because the LiveSave tool looks at impact being able to be disaggregated by specific interventions, we can look to say which main interventions would be most important when I'm trying to address the high burden of neonatal deaths, which are directly related to preterm birth. Next slide. So as I mentioned, the full scale up of all of these interventions, the most ambitious scenario that we analyzed would have produced, or we estimate that the reduction in the number of deaths was 86% of the neonatal deaths due to prematurity. We could reduce 3/4 of the ones related to intrapartum related complications, as well as similarly 3/4 of those related to infection, directly related to sepsis and pneumonia. In parallel or in conjunction with our analysis of the impact in terms of what's the mortality change or mortality reduction, we also conducted a costing study. And so our costing was sort of paired with, if we were to scale up these key interventions, what would be the associated costs? And so by applying an ingredients-based approach, which means these are the key components, which you can see broken out into those subcategories of drugs and supplies, for example, workforce or personnel costs, the total costs of $959.3 million are the costs that we're estimating associated with scaling up that inpatient care for those smallest and sick newborns. So our goal was to sort of look at what gains or what good we could accomplish, but pairing that with an assessment of what are some of the costs and what are the resources that would be required to achieve those gains. Next slide. So for the conclusion, I'm going to turn it back over. I'm sorry, for the next section related to sort of the current world that we live in and what is the context, what do we do sort of now in the context of the current pandemic? I'm going to hand the slides back over, hand the presentation back over to Ms. Walter for a presentation about the impact of COVID-19, which we all know has been profound.
Hi, actually, this is Judith. I'm going to go through slides on the strategic objectives that we designed for looking at action across various areas for ending preventable newborn mortality, and then we'll go to Ornella. So on the path to 2030 and to meeting the SDG target, we need to revitalize advocacy efforts to create actionable policies. You'll see that there are a number of things here that we need to do. And essentially, in the world of advocacy and policy, a country's laws and regulations really need to assure health security for women and their newborns, including those belonging to the most vulnerable groups, such as migrants and refugees. And they also need to be aligned with international and domestic human rights standards, most notably the Convention on the Rights of the Child. A large proportion of newborn deaths and disability would be prevented by refining existing systems, as you heard from Victoria's presentation, and ensuring that newborns and their families are able to access the care they need, and by ensuring rights-based and family-centered approaches and a focus on quality, equity, and dignity. And at the same time, governments and other actors need to work collaboratively to scale up comprehensive interventions along a continuum of care to ensure that health systems are providing full access to quality, essential, and special newborn care, including intensive care. And further, to ensure we're moving in the right direction and making the right decisions about care, we need accurate, reliable data for decision-making and accountability. Next slide. So to create our framework for action, we used the ENAP objectives and adapted them to focus specifically on small and sick newborns. And as you'll see in the slides for each objective, we used the Born Too Soon framework of invest, implement, inform, and innovate to frame action across the 5 objectives. And we listed several illustrative examples for each, and I'll highlight some of those in as I present each objective. It's important to note, however, that countries will need specific plans using available data and information. So with respect to Objective 1, strengthen and invest in care around the time of birth and care for small and sick newborns. This one was, we emphasized the provision of care, as I just said, for small and sick newborns. So a slight adjustment to this language that previously used for ENAP. And while many lives can be saved with quality maternal and newborn care, country stakeholders need to plan for and invest in care around the time of birth, as well as inpatient care for the small and sick newborn. And we can invest in assessing available maternal and newborn care in humanitarian settings, for example, and ensure that international newborn care standards and guidelines are adapted and available in facilities. And we can also improve data collection efforts to increase our understanding of where, when, and why newborns are dying. So on strategic objective 2, on the next slide, most births, as you all know, now occur in healthcare facilities, and this offers a really unique opportunity over the next decade to reach women and newborns with improved care. However, health system improvements really need to more intentionally focus on improving the quality of care, including they need to create a hospital environment that actively welcomes and engages parents in the care of their newborn. It's important that governments ensure that each level of care has the necessary staff, equipment, commodities, and diagnostics to deliver the care that is needed, and that longer-term outcomes for newborns with disabilities are being tracked to better assess the impact of inpatient care and services for early childhood development. And next slide. So regarding strategic objective 3, where we're focusing on closing the healthcare equity gap and accelerating progress to the SDG target, we need to develop and enact UHC policies, eliminate social and financial barriers to care with particular emphasis on female newborns, use data to design context-specific action plans, and design financial schemes that protect families from catastrophic out-of-pocket expenses. Next slide. Thank you. So for strategic objective 4, where we're harnessing the power of parents, families, and communities, we used in the document the framework for integrated people-centered health services, which promotes empowering and engaging people and communities in care. In this case, the small and sick newborn and often mother, father, or other caregiver are at the center of that continuum, the integrated people-centered health services continuum. It's very critical that we promote family-centered care principles in the care of small, sick newborns, that we're connecting community health workers with local organizations, community outreach for post-discharge follow-up of vulnerable newborns, that we're also educating and engaging men to understand the needs and risks and the danger signs of pregnancy, childbirth, and the postnatal period, and that they become active partners in seeking and using care, and also that we're engaging parents in the design and use of new products and approaches to care for their newborns. We also know that right now too little information is available on small and sick newborns, especially in low and middle income countries, and most especially in humanitarian settings. We need accurate, reliable data to facilitate planning and decision-making as well as accountability. And we need to routinize the process of collecting and using population-based and facility-level data to advance newborn care in low-resource settings and to better measure quality of care, as well as outcomes and impact of particular interventions and programs. This will require, though, that health systems update how they identify, track, and measure small and sick newborns. And next slide. So we also spent quite a bit of time outlining research priorities to guide change. And we used for this exercise the description, discovery, development, and delivery framework. And with a lot of input from country level and global experts, we developed a list of research priorities across each of those areas. And within this broader framework, we're encouraging that researchers engage mothers and parents and community representatives where feasible in research design and monitoring processes. I'm not going to provide that table here because it is actually quite comprehensive and very in-depth. So if you all could please make sure to take some time and look at the research matrix that's featured in chapter 6. I think that you'll appreciate the information that is provided there. So ensuring that our newborns are thriving into the next generation, we feel strongly, and I think this comes out in the document across all of the chapters, is that everyone has a role to play. And we know that there is going to be considerable commitment needed to eliminate the burden of newborns who are dying from preventable causes and to support their development across the life course. It's a commitment of political will, funds, resources, time, focus, and dedication. And all stakeholders in health and sustainable development really need to consider their own potential for action and move forward. So now I'd like to turn it over to Ornella, who will be talking about modeling and data collection around newborn during this time of COVID.
Okay, thank you very much, Judith. So it's a pleasure for me to connect, to make the linkages actually between the presentation on the need of action to accelerate the progress and what we are facing today with the COVID pandemic, and what would be, because the big question, what would be the changes and the additional efforts that are required to ensure this acceleration of progress despite the COVID-19 pandemic. You can see in the slide in the left the curve of reduction of neonatal mortality, and in blue particularly the type of acceleration that would be required in order to reach SDG 3.2. And the big question is, what will be the impact of COVID on this progress? We would like to have acceleration, but actually COVID is now a big challenge. And in fact, we were discussing the chapter, the colleagues discussed the importance of improving coverage quality because they are critical for ensuring neonatal survival and thriving. At the same time, and we know the country have done a lot of progress during the past decade and achieving better survival and health for newborns. And now the big question is what will be the impact of COVID on already suboptimal coverage and quality of healthcare that we can see in so many countries. So in order to understand better both the COVID and especially its impact on neonatal health and survival, there are a number of efforts going on in terms of measuring and modeling. And I would like to summarize a bit what is going on, because we receive actually many questions related to that. So we are collecting, of course, as you know, the situation, the country reports from the different countries. Based on that, we produce the situation reports and the dashboards regularly, and where we can analyze and see the distribution of infection and deaths according to time, geography, and also age. And I will show a couple of slides on that after that. But fundamentally, it looks like that the newborns are not particularly affected from that point of view. And then we also conducting together with UNICEF rapid surveys that are looking at the disruption of services, because we all know that the COVID has impacted on the services that are provided to people in one way or the other. We will go more in detail later. And then we are using also modeling, because partners are actually we use the LIST tool to look at what are the indirect effects of COVID on the utilization and the coverage of maternal and child health services, and what could be actually the impact of COVID in terms of maternal and neonatal outcome in different scenarios based on different level of coverage or underutilization. And finally, there are also ongoing research that studies, cohort studies, and other type of studies that will help us to understand better the disease and both the direct and indirect impact on with the real data.
Ornella, you're breaking. Can you get closer to the mic?
Yes, I don't know. Maybe it's I'm always as you. Now it's better.
This is fine. Yes, thank you.
I think it's the line, however. Okay, so in these slides you can see the global distribution of cases, and then by age group, and you can see that in the bar on the bottom, which corresponded to the age group of 0 to 4 years old, we have the lowest case proportion of cases. So you can imagine newborns, just the first month is even less. And in terms of deaths, we have a similar picture, because we know COVID is affecting people in older age. And again, the probability, the likelihood of being reported as a death is very small in the early age, because the majority of deaths are happening in the mature or older age, as you can see. So we know that the direct impact of COVID on newborns seems to be low. We are still discussing if there is even vertical transmission. Probably there is a little bit of vertical transmission, but it's not been confirmed 100%. But certainly the virus of COVID is much less it affects much less the pregnancy and the newborn compared with other viruses in pregnancy, like I don't know, rubella or. Instead, COVID-19 as having already quite a negative impact in terms of availability, accessibility, quality of services for pregnant women and their newborns. And here I report some of the data from modeling of the indirect impact of COVID-19 that has been done by basically two big reports. So one has been done looking at the data from 132 studies, and is by the Guttmacher Institute. They estimated that in these 132 studies, a decline of 10% in service coverage of essential pregnancy and newborn care could result in additional 28,000 maternal deaths and additional 168,000 neonatal deaths. And this is only for a 10% decline in service coverage. And the second study has been published in the Lancet, and has been done by the colleagues of John Hopkins using the LIST tool, and on one hand, and they have looked at different scenarios, different coverage scenarios. And this, for example, is with a coverage reduction between 10 and 15% and wasting increase of 10%. Over 6 months, we will have an additional number of child deaths up to 253,000 and 12,200 additional maternal deaths. And this is looking at, this is only with the more with the scenario where you have a reduction around 15%, let's say, over 6 months. But if we compare with the numbers are a bit similar to what came across through the two different studies, even a bit worse maybe with the LIST tool. But now I want to show also what are the real data that we are collecting from surveys. You can see a summary of the results of two surveys. The one is from WHO on the essential service, and the other one is the UNICEF situation tracking. And that both have been done, these data have been collected between May and June. And they show that in reality, you know, they are slightly different because slightly different number of countries, but in reality, you can see that there is a much bigger decline on the utilization of services compared with the modeling, where you can see family planning services reduce 75% or to 47%, or antenatal care also around 50% reduction, partial or full disruption of services, if you like. And but even health facility deliveries that are reduced around 33–39%. So that are big disruptions, and we have not reached the peak of the epidemic in all countries, by the way. So because as we know from the news, in many countries we are still having an increase of this. So it's very worrisome for us, and we need really to work much more to ensure that essential services are, maternal and neonatal services are essential, and ensure that these services are made available and with quality. Now, I would say that a lot of this decision in terms of public health have been taken in relation to COVID as had to be taken on the basis of rapid services or estimates or models, because the COVID-19 disease is something new. It's not something that is not a disease we knew before. And so a lot of assumptions have been done, and but certainly we can see that the indirect effects of the COVID pandemic are going even beyond health, are going also in other spheres, if you like, and particularly for the children and for their mothers, impact also on the mental health, on neurodevelopment, nutrition, and the socioeconomic aspects. And for the countries to respond to the challenges, they really need real-time data. And and we don't have yet high-quality primary research data on the impact of the disease on these essential services. At the same time, many countries are facing challenges in terms of their monitoring system, particularly for newborn health. We discussed over the past webinars are not particularly good, and we don't collect many times data in countries on deaths or causes of death or quality of care. So it becomes a challenge to be able to document also the impact of COVID in when the measurement challenges are there already in the countries. So one way of looking at better data, and one thing that the WHO is coordinating with other partners and around the world from, I would say, all countries, is conducting research, and particularly of interest for us, I think, are the cohort studies on pregnancy, newborn, and child outcomes and feeding as well. And trying to answer to those questions that I summarize here. For example, what are the effects of COVID-19 infection in pregnant women in terms of outcomes, maternal outcome, fetal outcome, neonatal outcomes? Because we don't know yet, we don't have the full answer, the full picture about that. And then what is the clinical characterization, for example, of the management that is consequent to the characterization in different age groups. And again, in newborns, we know very little, in fact. And finally, what are the effects of COVID-19 pandemic on the coverage and quality of the essential services? And we know that this population-based cohort studies will help us very much to look really at all those aspects. I would like to conclude by saying that the benefits of collaboration. So it goes also beyond the health services. It's important that all countries collaborated to share the data and share not only data but also that harmonize the protocols for collecting the data, so it becomes easy to compare. And this harmonized data from these cohorts have a lot to provide to us a unique opportunity to have much better quality information. And when it is also quality information, we can provide also stronger recommendation. We can share this recommendation immediately with national governments and care providers. And this real time, and these are more real-time data that can help much better the planning and implementation in relation to our maternal and child health services. And also can help to monitor the impact on the COVID-19 pandemic on the service in general for mothers and children. So, as the UN Secretary General said, while the impact maybe is not the direct impact, that doesn't seem to be high on women and children. However, the impact the indirect impact, the impact of COVID-19 are exacerbated in women for many reasons, and children are not the face of the pandemic, but they risk being among the biggest victims, exactly because of these indirect effects. So thank you very much. I think I close here with the COVID, and I would like acknowledge the contributors to the chapter 6 and to the presentation. I would like also to let you know that the webinar that we had planned on 29 July on the standards has been postponed, has been cancelled, and it will take place on 12 August. Basically, the next webinar will be on 12 August, and we'll focus on introducing the new standards of care for small and sick newborn, which is a new document that we are making available in August. And I would like also to let you know that later in the month, probably on the 26th, there will be also the launching of the new target, every newborn action plan, new coverage targets, 2020 to 2025, as well as the report for the 2019. And thank you very much. And I would like to hand over to Bene for the discussion.
Thank you very much, Ornella. Thank you. We got a few questions for the panelists today. The first few one for Dr. Shu. I will read them out, and if you have more questions, please type them, and the panelists will answer them. Victoria, we have a question about the baseline and targets to save the life of mother newborns. What were those, and how did you assess the feasibility of achieving those coverage targets?
Sure. So for our platform, we're collating data from population-based household surveys. So our standard approach uses coverage estimates for key interventions that we're able to get from population-based household surveys. One of the challenges is that those are conducted only every 5 years in low resource settings. One of our challenges is that there may not be coverage estimates available for all important interventions that are collected with this approach. So what we've started to incorporate is data from health facility surveys. So health facility surveys, which are conducted in perhaps a subset of those countries, to be able to tell us about the availability of services, of resources, including trained staff, commodities, et cetera, allows us to use readiness as a proxy for quality. And so in some ways, the information that we can get from a population-based nationally representative survey is combined with the information that we would be getting from a from a health facility survey to be able to understand what is the quality of services that are received. So one of the challenges for us, and I think part of the reasons we were excited to get involved in this chapter, sort of calling for action, is additionally, as folks are developing programs and as they're testing new interventions, part of it is also to increase the availability of metrics and data to inform where we are on tracking some of these key interventions. Because again, for some of them, we're able to derive estimates for some of them by maternal self-report from a population-based household survey, but that also is limited. In terms of scenarios and how we selected the targets, those were done based largely upon the work that was done for the Lancet Every Newborn series. And so those were based upon a consultation with experts to determine sort of not necessarily what would be feasible, but initially sort of what is the what is the potential benefits, or sort of what is our sort of gold standard, or what is the most good that we could achieve. And so those were developed in consultation with key experts. There were two other questions, and I'm not sure if I should cover those for related to how it quantifies the interventions for synergy, and then also for interventions for smaller premature infants. And so I'm happy to I'll take direction from the facilitator whether you want me to cover those now or whether.
Yes, please. No, go ahead. Go ahead.
So Ms. Paula had asked, Ms. Quigley had asked about how does the LiveSafe tool take into account interactions between the different conditions or interventions and synergies rather than dealing with interventions discretely? So we do model risk factors such as poor adverse birth outcomes like small for gestational age or prematurity which mediates the impact of those interventions. We don't account for synergies because the way that we are quantifying the impact of those interventions is based upon sort of a systematic review or a meta-analysis or something that looked at the impact of those specific interventions. So when we quantify it, the advantages are, one, we don't double count. So we apply sort of the impact of each intervention in a way where we're going to be able to say these are mutually exclusive, these are deaths which are accounted for, deaths which are prevented based upon the specific intervention. And so in that way, we don't sort of have any evidence from literature about synergies. But what you may be referring to is like a health system strengthening approach or an overall quality initiative. So our conceptual framework says that if countries and programs and stakeholders are driving those key changes like health system strengthening, workforce training and supervision, et cetera, all of those things are going to improve coverage of key interventions so that high quality care is delivered at those important time points. So that's sort of how we address the synergies of those programs or initiatives. The one question about the key interventions, and on slide 16, we have shown, so are there key interventions? The question was, are there key interventions that would prevent small or premature deaths due to prematurity during the neonatal period for women who are pregnant? And so there are antenatal care interventions, again, as an evidence-based platform based upon the literature. These antenatal interventions provided to the mother at the time when she is receiving antenatal care would reduce the risk of, again, those adverse birth outcomes, which will sort of have a trickle-down effect to impact prematurity as a cause of death. That sort of, and I'm happy to answer any additional questions. I know that those were sort of the main sort of, how does the model work and how does it relate? I'm happy to answer any more questions folks may have.
Thank you very much. I had a question about the advocacy part for Judith. Judith, you mentioned that there is a need to ramp up advocacy to create the right environment for policy to improve quality of care for newborns. Can you talk a little bit more about that?
Sorry, I was having trouble finding my mute button. Yes, absolutely. So as we all know, there's when we look at a health system and talk about health system strengthening, we all consider that there's an enabling environment, and that enabling environment includes the policy and legislative framework, as well as standards and guidelines for care. And so we know that right now, a number of countries are really looking to other global bodies, such as WHO and others, to really frame the health system's needs for care of the small, sick newborn, as well as prevention of prematurity, et cetera. It's really looking at that continuum of care for mothers and newborns. And so it's a matter of making sure that we're working with those stakeholders at the country level to ensure that global guidelines, global standards of care are making their way to the country level to, in fact, inform them the work that they're doing in terms of their policy, their legislation, and the rollout of those standards and guidelines. And so it's actually it's a very real cascade effect. And I think we've seen in other arena where that's been very successful. I want to just highlight again that I think, Ornella, you mentioned at the end of the slide presentation here that we will be looking at standards of care for small and sick newborns in the coming weeks. Those have been under development for probably about a year or more, maybe 2 years now. And that is one aspect of that policy environment and that advocacy work. And just very quickly, another piece of that is, of course, at the community level and with families, parents, making sure that they have a voice, that they're empowered to change or influence the design of health services and hold governments and stakeholders accountable for the services that they're actually delivering. And that can be done through a number of ways, including, parent committees, community committees, engaging communities with local government, et cetera. So there's a whole lineup of actors in the world of advocacy and policy, and it's really a matter of igniting those through government interaction, implementing organizations, civil society, and of course our professional associations at the country level.
Thank you. There is a question about maternal health expert here and how to engage them in the discussion, because one participant mentioned that even this webinar, you might find that there's few of them. How do we hold maternal health expert accountable for pregnancy outcome and have them on board with this conversation on neonatal health? And that's really much for all of you. It's not specifically for one.
I can take the question because being co-chair of the enough groups global level, I know we are working pretty closely with the maternal groups. And in fact, the enough also, now that we are developing the new targets, we have a number of targets that are also maternal. For example, the coverage target include antenatal care, childbirth care, postnatal care for the mother as well. So we are working closely to align even more the programs, the neonatal programs, and with the maternal ones, because we look at a lot mother and newborn together as a diet that needs to be protected well before the birth of the baby. And in fact, in the concept of transforming care for every small and sick newborn also gives a lot of space to the maternal, not only health, but also involvement, participation, because in the care of the baby, something that, was not really in the picture, at least globally, some years ago. So, and because we recognize that if you want, the time, if you want to really improve the not just mortality and survival, but particularly the development of the child, the thriving agenda, we need to work very closely with the families and beyond and the community. So that is, and with and also looking at the continuum of care. So a lot of intervention that are, we are aware that a lot of intervention that can prevent the neonatal mortality of disease are starting in pregnancy. Yeah, so yeah, they are, the maternal community is certainly important, I agree, and are our partners in these efforts of improving neonatal health. But still, 7,000 deaths every day.
Thank you very much, Ornella. And thanks you the floor. There was a question directed to your slide on COVID-19 from Jeffrey Irene asking how you could provide incentive for country to have already limited resources to fight the pandemic, to invest in research and data collection and health service directed at the newborn, when actually we know the newborns are not the most likely to be affected by COVID-19 or the most likely to not survive. So how would you motivate country to invest in newborn in this case?
But actually, I think that these discussions and then these numbers that we are providing, where we really a reduction on the access of services, or utilization of services, which depends depends also on the policy, depends on the communication, depends on the perception of safety of services and so on. All this can help to understand how negative can be the impact on neonatal health. So the newborns are the future, basically, are the children of the future. So one thing is to say, okay, they don't die much of COVID-19, so there are a few cases, so no need to prioritize, which is true, maybe, but compared to other groups in terms of urgency. But then when you look at the coverage of the potential, of the actual, what is happening in terms of utilization of services, reduction of access to services, and the mortality that derives from that, then it becomes a priority, because you cannot have, I think it's acceptable to have extra maternal neonatal mortality in stillbirths just because of how certain decisions are taken, or some policy or certain priorities are decided. And I think we have a space by understanding better the pandemic, by understanding better who is affected, by understanding better how we can protect ourselves, and what are the policy also that work best. Then we can also avoid, this enormous reduction on access to services for women and children. because otherwise we will face huge mortality in these groups. Maybe it will not be called mortality due to COVID, but still will be more infant mortality, child mortality, maternal mortality. This is what I'm trying to say. So we need to work on both tracks, the COVID direct effects and the indirect effects.
Thank you very much. I see that Victoria, I think, wants to add to that answer and to answer Jeffrey's question.
No, had summarized it well at the end to sort of to delineate as the direct effects, which admittedly, I think everybody have been focused on the ability of low resource settings to handle, how many ventilators are available, et cetera, how much PPE, et cetera, to handle the pandemic directly. And I think that the analysis that had been presented, that was mentioned, that looked at where we were trying to estimate the indirect effects due to service disruption. I think your point is exactly why that paper was well received, is because people were concerned that, we can delay services. We can say, well, we'll put up sort of like in sort of high income countries, we've said, oh, if it's not elective surgery, et cetera, we can delay those. We can transition to other approaches to offer care. And what would be some of the strategies that could be implemented in low resource settings? Because it's the service disruption. You can't tell a woman who's about to have a child, we'll come back when the facility's been sanitized and when we have enough PPE. So the idea is, as countries and programs and individual contexts are developing strategies, what they're trying to estimate is mitigation. And so for, I feel bad because I know there's that saying that if all you have is a hammer, everything looks like a nail. But I will say that one of the benefits, and I know everybody from the pandemic is tired of hearing about modeling studies because it just all has to do with the assumptions. But part of the advantage is that with looking at some of the potential impacts, you could estimate what is the essential package of services that I have to preserve. And because of the reasons you're mentioning, which are that, countries have few resources. And so how do I allocate those to ones which are going to have the greatest impact or the greatest benefit? So as much as other approaches should be done for universal health care and for sort of maternal, newborn, child health across the spectrum, what right now is our sort of most essential? And so I think that your comment is exactly right, which is these are settings which resources are few, and so that means resource allocation becomes that much more scrutinized. So thank you.
Thank you very much. That is the end of our question and answer session. I would like to hand over to Ornella, who will close this webinar.
Okay, thank you very much to all for your participation. And so I hope that with this final webinar, you will feel also comfortable to advocate with us on the importance of expanding both the coverage as well as the quality of services for small and sick newborns. And this is important in general to reach the SDG, and it is even more important now in the context of COVID-19, where some of the gains of the past years might be challenged. So with this, I would like to invite you also to the webinar on the 12th August, which will be a bit more technical on what are the standards that we think are important to be promoted in countries for strengthening the care of small and sick newborn, particularly at the secondary level and tertiary level facilities. And thank you very much for your participation, and have a very good day and stay safe.
Thank you. Bye.
Thank you so much.
Thank you all.